Hey everyone, so for my master's project, I decided to do lumbar stenosis. I did this mainly due to how common of a condition it is in a variety of different clinical pictures and the best approach for diagnosis, treatment, and evaluation. Starting off, lumbar stenosis is the narrowing of the spinal canal in the lumbar region of the spine. Lumbar stenosis is common with an aging population. It has been shown that with people over 40, a range of 23.6% to 77.9% will potentially have moderate stenosis, and 8 to 34% will potentially have severe stenosis. It is important to include that out of these patients, most will not experience clinical symptoms. It is of note, however, that when patients do become symptomatic, it is usually around their seventh decade of life or around their 70s. This condition can be present at birth or through acquired means. However, acquired lumbar stenosis is more common. Risk factors for lumbar stenosis will be an increased age, obesity, smoking, and repetitive stress to a patient's back. Typically, the patients who are symptomatic with lumbar stenosis will present with neurogenic claudication, or defined as leg pain that is relieved with bending forward. As we can see here in this picture, this is a shopping cart sign usually seen in patients with lumbar stenosis. Since they get relief with bending forward, they may walk like they're holding a shopping cart so they can walk without pain. Patients may also experience back pain or sciatica. Appropriate physical exams will include a neurological, musculoskeletal, and vascular exam. Neurological exam will reveal intact deep tendon reflexes. Vascular exam may show decreased or absent dorsalis pedis pulses due to the common coexistence of neurogenic and vascular claudication. Musculoskeletal exam will reveal relief when the patient leans forward in a wide-based gait with a positive straight leg raise test. Imaging is often indicated for these patients, with MRI being the preferred imaging of choice. If an MRI is contraindicated, it's appropriate to order a CT myelogram. X-rays are also an option and may be ordered to show anatomical positions and dynamic stability to reveal the presence or lack thereof of spinal listhesis. MRI will reveal neural impingement and stenosis. C2 will reveal bony structures the best, and can diagnose disc stenosis with the downside of extra radiation. X-rays may display loss of disc height, vertebral alignment, and osteophyte formation, but warrants a CT or MRI to aid in diagnosis. It is important to note that MRI alone cannot diagnose lumbar stenosis, as lumbar stenosis is a clinical diagnosis. A combination of the clinical picture of lumbar stenosis and imaging as an adjunct should be used for diagnosis. When a provider suspects symptoms of lumbar stenosis, a differential diagnosis of peripheral artery disease, peripheral neuropathy, degenerative disc disease, and Codd-Quine syndrome, and severe lumbar spine stenosis should be recognized. The diagnosis of lumbar stenosis can be distinguished from the differential diagnosis list previously stated by alleviating the back and leg pain by leaning forward. Transitioning into treatment. The initial treatment of lumbar spine stenosis will be 4 to 6 weeks of physical therapy with 2 to 3 sessions per week. Analgesic medications, such as NSAIDs, is also a first-line treatment in lumbar spine stenosis. Other medications, such as gabapentin, are helpful in reducing neuropathic pain, as well as helping in walking distance due to decreased radicular pain in the lower extremities. The most common non-surgical spine procedure for lumbar spine stenosis is epidural steroid injections. Normally, these injections will provide temporary relief for around 2 weeks to 6 months. Follow-up after the first injection is around 3 to 4 weeks. The next follow-up should be 4 to 6 weeks. Nerve blocks are another viable option for treating lumbar spine stenosis, with patients showing 64% excellent results, with the caveat that this treatment was for mild to moderate stenosis and no long-term results reported. Radiofrequency ablation is utilized with patients that have soft tissue stenosis, but with mixed results of only 58% having symptomatic relief in 6 months. Surgical options are viable after conservative measures have been exhausted. Surgeries vary from intraspinous spacers to minimally invasive lumbar decompression, endoscopic decompression, invasive open decompression surgery, limited versus multi-level decompression surgery, and decompression surgery with or without fusion. These surgical options are often contingent on the severity and the location of the stenosis. Complications from not treating lumbar spine stenosis would include loss of sensation in both legs, cauda equina syndrome, and worsening back pain. As stated, a rare but serious complication from untreated lumbar stenosis is cauda equina syndrome. Due to spinal compression from stenosis, the disc may lead to expulsion into the spinal cord. Symptoms of cauda equina syndrome include extreme low back pain, saddle anesthesia, bladder retention in the early stages, and incontinence in the later stages, as well as bowel incontinence. Lastly, complications from surgery can arise. Common complications result in roughly 5.9% of patients and include blood vessel injury, poor vertebral reduction, guide wire breakage, screw breakage, malposition, and cerebrospinal fluid leakage. It is important to note that these different complications arise in different percentages through different spinal surgeries. And these are my references.